Welcome to the Black Belt Nurse Podcast. I'm your host, Bill Schuler, and this is a podcast where we talk about anything and everything workplace violence related in the healthcare sector. Don't forget to like and subscribe to this channel and hit that notification button so that you're notified when new episodes drop. Today, we're tackling a topic that's become increasingly critical in healthcare settings: flagging patients who may be at risk for violent behavior. It's a conversation that sits at the intersection of worker safety, patient care, and ethical practice. And it's one we need to have thoughtfully and honestly. Violence against healthcare workers has reached crisis levels. We're not just talking about rare incidents anymore. We're talking about a pervasive occupational hazard that affects nurses, physicians, technicians, and support staff across nearly every healthcare setting. Emergency departments, psychiatric units, medical surgical floors, no area is immune. The question isn't whether we need to do something. The question is, what's the right thing to do? Let's start with the reality on the ground. Healthcare workers face violence at rates far exceeding most other industries. Some estimate that up to 95% of healthcare workers have experienced workplace violence at some point in their careers. In emergency departments specifically, the numbers are staggering, with studies showing that nurses experience assaults at a rate of more than 2 per hour nationwide. And here's what really matters. This isn't just about statistics. Every incident of workplace violence has ripple effects. It affects the mental health and well-being of the staff involved. It can lead to burnout, turnover, and even PTSD. And when our healthcare workers are traumatized and exhausted, patient care suffers too. The regulatory landscape is starting to catch up with this reality. The Joint Commission now requires hospitals to have workplace violence prevention programs. Some states have enhanced criminal penalties for assault on healthcare workers. There's even been proposed federal legislation, such as the Workplace Violence Prevention for Healthcare and Social Service Workers Act. That would mandate specific protections nationwide. But having regulations is one thing. Implementing effective prevention strategies is another. This is where flagging comes in. So what exactly is flagging? At its core, flagging is a communication system. It's a way to alert healthcare workers that a particular patient has a documented history of violent or aggressive behavior, so they can take appropriate precautions. Think of it as situational awareness, giving staff information they need to protect themselves while still providing quality care. Flagging can take different forms. Some hospitals use visual cues, like colored wristbands, signs posted outside patient rooms, or symbols on physical charts. Increasingly, though, flagging happens electronically through the electronic health record, or the EHR. You might see a pop-up alert when you open a patient's chart, or a flag in the patient's header that says something like behavioral alert or safety concern. The idea makes intuitive sense, right? If a patient has previously assaulted staff, threatened violence, or displayed aggressive behavior, the care team should know about it. They can take precautions, having 2 staff members present during care, keeping the door open, removing potential weapons from the room, involving security, or creating a specific care plan that addresses the behavioral issues. In some settings, flagging appears to work. One study found a significant decrease in violent incidents when flags were appropriately implemented, at least initially. Staff members in various hospitals have reported that flags help them feel more prepared and safer. When you know what you're walking into, you can be ready. Let's talk about the legitimate benefits of flagging systems, because they do exist. First and foremost, staff safety. And this isn't abstract. We're talking about preventing actual physical assaults, verbal abuse, sexual harassment, and psychological trauma. When frontline workers know that a patient has a history of violent behavior, they can implement safety protocols proactively rather than reactively. They can request backup. They can adjust their approach. They can be prepared. Second, legal compliance. In Ontario, for example, employers are legally required to inform workers about risks of violence if those workers might encounter the person posing the risk, and if that risk could lead to physical injury. Flagging is one way hospitals meet this legal obligation. It's not just good practice. In some jurisdictions, It's the law. Third, care planning. There's something important that often gets overlooked. Good flagging systems aren't just about notifying risk. They're about developing therapeutic approaches. A well-designed flag should include not just, this patient might be violent, here's what triggers this patient's aggression, and here's what helps de-escalate this patient. It becomes a tool for better, more individualized care. When done right, flagging can actually improve the therapeutic relationship. If I know that a patient becomes agitated when they feel rushed, I can intentionally slow down my approach. If I know that a patient responds better to male versus female staff, or vice versa, we can plan accordingly. This isn't discrimination, it's meeting patients where they are and adapting our care to reduce everyone's distress. But, and this is a significant but, flagging is far from a perfect solution. In fact, the research reveals some serious problems with how flagging is implemented in many healthcare systems. Let's start with effectiveness. While some studies show short-term reductions in violent incidents, others show no sustained benefit. Flags don't prevent violence if they're not accompanied by actual resources and interventions. A pop-up alert that says, "Caution, behavioral alert," doesn't tell me what to do. It doesn't give me extra staff. It doesn't provide de-escalation training. It doesn't address why this patient is behaving aggressively in the first place. Multiple studies have found that healthcare workers perceive flags as unhelpful precisely because they don't provide actionable information or solutions. It's like getting a weather warning without the forecast. You know something might be wrong, but you don't know what to do about it. Then there's the issue of accuracy and standardization. Who decides when a flag goes up? What behaviors warrant flagging? How long does the flag stay active? The research shows massive variation across hospitals, even within the same health system. Some institutions flag patients for threatening behavior, violent acts, or weapon possession. But others flag patients for things like demanding pain medication, or being difficult, or having complaints about care. And here's where it gets really problematic. There's growing evidence of bias in how flags are applied. Multiple studies have found that Black patients are significantly more likely to be flagged than white patients, even when controlling for actual documented incidents of violence. Young adults, male patients, publicly insured patients, these groups also show higher flagging rates. And these flags have consequences. Patients with behavioral flags have been shown to receive less testing, less treatment, and are more likely to leave against medical advice. This brings us to the heart of the ethical dilemma. On one side, we have the legitimate right of healthcare workers to a safe workplace. Nurses, physicians, and all healthcare staff deserve to go home to their families without having been assaulted. Full stop. That's non-negotiable. On the other side, we have patients' rights to unbiased, high-quality care. We have concerns about stigmatization. We have privacy issues. We have the fundamental medical principle that every patient deserves to be treated with dignity and without prejudgment. And sitting right in the middle, the reality that many patients who exhibit aggressive behavior aren't doing so because they're bad people. They're in pain. They're scared. They're experiencing psychiatric symptoms. They have substance use disorders. They have dementia. They're having the worst day of their lives, and their behavior reflects their distress, not their character. So how do we balance these competing values? The research suggests several principles. First, flags should be reassessed regularly. A flag placed during an acute crisis shouldn't follow a patient indefinitely. Canada's largest psychiatric hospital reassesses flags at every transition of care. When a patient moves to a different unit or is discharged and then readmitted, the flag is reevaluated. Is it still necessary? Is it still accurate? This dynamic approach prevents flags from becoming permanent scarlet letters. Second, flags need clear criteria and oversight. Who can place the flag? What documentation is required? Who reviews flags to ensure they're appropriate and unbiased? Without these safeguards, flagging becomes arbitrary and susceptible to individual biases. Third, flags should include actionable information, not just warnings. Instead of patient might be aggressive, a flag should say patient becomes agitated when multiple staff enter the room. Approach with single care provider and explain all procedures before touching patient. That's useful. That's therapeutic. Fourth, education is critical. Both staff and patients need to understand what flags mean and don't mean. A flag isn't a punishment. It's not a moral judgment. It's a clinical tool meant to facilitate safe, effective care. When we frame it that way, and when we educate everybody about the relationship between safety regulations and privacy protections, this is when we can reduce the stigma. So where does this leave us? I believe, and I think the evidence supports this, that some form of risk communication is necessary. Healthcare workers need to know when they might be entering a dangerous situation. But the way we're doing flagging now, it's flawed, it's inconsistent, it's sometimes biased, and it's often ineffective. We need better systems. We need systems that are transparent about criteria and processes, systems that include regular review and sunset provisions, systems that focus on de-escalation strategies, not just warnings, systems that are monitored for bias, and systems that are part of comprehensive violent prevention programs that include adequate staffing, de-escalation training, behavioral health resources, and leadership accountability. We also need to acknowledge that flagging alone will never be enough. Workplace violence prevention requires a multi-layered approach. Environmental design matters. How we lay out our spaces, where we position exits, how we ensure visibility. De-escalation training matters. Adequate staffing matters. Access to behavioral health expertise matters. Organizational culture and leadership commitment matter. A flag in an EHR is just one small piece of a much larger puzzle. And here's something else we need to talk about: the root causes. Why is violence against healthcare workers so prevalent? What systemic issues contribute to patient aggression? Let me bring this full circle. The question of whether to flag patients at risk for violence doesn't have a simple yes or no answer. It requires us to think critically about competing values, to acknowledge both the legitimate safety needs of the healthcare workers and the legitimate rights of patients, and to commit to continuous improvement of our systems. I believe we can and must find ways to keep healthcare workers safe while providing equitable, unbiased, high-quality care to all patients. But that requires better flagging systems than what most hospitals have now. It requires ongoing education, clear accountability, regular auditing for bias, and integration into comprehensive violence prevention programs. Most importantly, it requires us to see patients and healthcare workers not as adversaries, but as human beings deserving of safety, dignity, and healing. Today, we've scratched the surface of patient flagging for violence risk in hospitals. We've looked at the regulatory landscape, the potential benefits, the significant challenges, and the ethical tensions inherent in these systems. But this conversation is far from over. In future episodes, we'll be digging deeper into the nuances of this topic. This is complex, important work, and I'm grateful you're here engaging with these difficult questions alongside me. Don't forget to like and subscribe to this channel and hit that notification button so you're notified when new episodes drop. Until next time, stay safe, and I'll see you in the next episode.